king of somewhere hot.
Hey guys, welcome back to the back of the bus. That seems to be the continual theme that happens with our training videos. Like I've promised you a couple times now, I wanted to make sure that based on the EMS assessment that we did, it's been 3 months ago now, that we took the lessons that we needed to polish up on a little bit and spend a little bit of time talking about them. So tonight I get to hang out with the guys from Brad's platoon. Nice. We've been trying. How long we've been trying to make this work now? For a month or better, at least. Luckily Brad went away, so I got to come hang out with these guys today. And we're going to talk about Supraglottic Airways. And we also, fortunately, have a special guest. We, ironically, have the inventor of and the developer and marketer of the King Airway with us. So everybody give a big round of applause to Captain Val King of King Airway fame. Anyway, so when we did the EMS assessment, you guys will remember that when the medics came in, we had them do intubation. We actually had them go through an intubation. But for you guys, we put the King Airways out. And there was this whole mixed bag of answers that we got about, like, how do we size them? When do we use them? Is there a time we shouldn't use them? How much air do we put in them? So let's talk about some of that. So, Bud, first of all, like, who should use this? Like, who's going to use the King Airway?
All of us, the advanced EMTs and paramedics, we all have places and needs for them.
Okay.
That we can use them.
So it's not just an advanced thing?
No.
All right. Not. Okay. What do you think?
I agree with Bud.
You agree with Bud? What should you do with your hands? I agree. And I think that, in fact, if you look at kind of some of the literature about this, we as paramedics get fixated on that intubation. And we all know that that's bad. And in fact, that's why these things have become so popular in EMS systems is because we tend to not be great at intubation. We tend to interrupt CPR, which, let's be honest, this is where this is going to get used a lot. We interrupt CPR, which we know we shouldn't. And we're not great at intubation, although I will tell you, and I can prove statistically that our department is certainly better than the norm. But we still have occasions where I truly believe that this is the smarter thing for us to do. So where are these, by the way? Like, I had to scavenger all over. Where are these in our rigs and in our bags?
Up on top of the shelf with our airway, our non-rebreathers, our cannulas. Also, some of the oxygen bags have them with the OPAs and the NPAs.
So, but I remember when before we bought these new bags, we had that kind of funny pouch that was on the side because a bunch of the guys had gone to the airway class and thought it was really important. And I agreed, actually, that it was important that we have those King Airways, but they kind of went away. So is there some in the bags?
Occasionally I find them in there. The general consensus was to improve the longevity of the bag by reducing what was in it.
Okay.
So, and
no more
10-pound
bag?
Exactly.
Nice.
So we figured, the Kings, they have their places, and we can use them along with the suction. We'll probably need the suction if we need the King, so we can put it in its own bag next to the suction. And when we grab that, we can grab the Kings.
So kind of what I'm hearing, mostly wink, wink, what I'm trying to get across to everybody is I'm glad they're in here and not in the bags, because I believe, and if you listen to me talk, especially RSI, I believe the best place for us to manage airways is back here. Like you mentioned, better light, suction right here. Every piece of equipment we need right here. Multiple sources of oxygen. So are we going to manage somebody's airway by the side of the road or in their house? Absolutely we are. But I think that especially when we start tiptoeing into the advanced airway thing, that maybe we ought to think about trying to get the patient out here more sooner than later. And I know that's not always possible. So when are we going to use these things?
On our cardiac arrests or our unconscious no gag reflex patients.
Why no gag reflex?
Because it's a contraindication.
Right, good. And you're going to get a vomit geyser, right? Okay. So is there a time when you wouldn't? Do you know, and you mentioned contraindications just now. Do you know what they are?
Height under 4 feet is a contraindication. Okay. We talked a little bit about esophageal diseases,
Okay, good.
whether it's like varices or something.
Sometimes that's hard to know, though, right? Like, you're
If
not
they've
going
got
to know.
if they've
as soon
got a
as
known
they-
history, if it's relayed by family or somebody I've seen,
Right.
and then I can't remember any of the other ones.
So, you guys all know that I teach for the Difficult Airway course. One of the acronyms that we teach, and for you guys that are watching this video, I've attached a PDF from this month's EMS World Magazine that talks about it, alternative airways, and it talks about 3 of the acronyms that we use in that course. One of them is the LEMON acronym, which is a predictor of difficult bag valve mask. Difficult intubation. MOANS, which is a predictor of difficult bag valve mask. And then the other one that we teach of the 4 is RODS, which is predictor of when we may have a problem with this. Now, it's exceedingly rare that you have a problem with somebody, but RODS, the first one is restricted mouth opening. That's a big device and big balloon, and if somebody's got a small mouth, it becomes difficult to get that in there, especially if you're using a tongue blade or some other way to get the tongue out of the way. So R is restricted mouth opening, which ironically is probably one of the biggest problems with this for intubation. So if somebody's got a small mouth opening, they're going to be a real challenge for us to manage their airway. O is obstructed. If you think about it, when we put that airway in, if they've got an obstruction, whether it's swelling from a burn or it's meat or whatever in there, it does us no good to put that in there and try to ventilate if they're obstructed around their cords. So, and the other one is obesity. And the reason for that is these things don't work great when we have to bag a lot of pressure into them. And when somebody's obese and they got all that adipose on their chest and their abdomen, squishing their guts and squishing their lungs, we overcome that by bagging harder. So the obesity part of it's a big deal. Now, I'm a little portly. Had to change my shirt even to make it look a little less so tonight.
You look great.
Yeah, thanks. Can I fix obese? Can I make somebody a little less fat?
Yes.
How?
Position or displace them.
All right. We're going to talk about that in a minute. But you're exactly right. We can make somebody a little less fat. All right. So obese or obstructed is O. D is disrupted or distorted airway, okay, which includes from here clear down to the trachea. And that's what you were talking about. Those people that have got funky anatomy, or somebody that's taken a clothesline shot, or somebody that's got disrupted vasculature, that's going to swell and move the airway. So anything that's disrupted or distorted the airway is another relative contraindication to it. And then S is swelling. Again, angioedema, burns. So ironically, another good example. Just a couple days ago, the sheriff's office had a gal in a suicide attempt down at the jail that drank a bunch of cleaners, and her airway instantly swelled up. And she would have been a contraindication for that. So they're rare that we would see those things, but if you drop that in just kind of out of routine and habit, and you really notice that you're fighting to bag it, if you can kind of remember RODS, or at least what that's trying to overcome, which is higher pressures, all right, and difficulty insertion, those are really the 2 things that it boils down to. Those are the things that are kind of our contraindications. So, Bud, what size you got there? We got a 4. Is that because that was the one that was out in training?
Yeah, this is a 4. This
All right.
one was open. We carry various sizes: 5, 4, 3.
I'm gonna guess
2
2
and a
and
half
1.
and a 2.
God,
2 and a half and a 2. And sizing these, I guess we can move on to that.
Yeah, we totally. In fact, I will tell you, of all the problems that we came into, the thing that people just kind of, for lack of a better term, they used to swag on was sizing and inflation. So let's talk about those.
So pretty much all that info is going to be found on the packaging. You size it by the height of the person, which they have it here in feet or centimeters, and then on the smaller ones for the kids, they have it in inches or in centimeters as well. They also have to what you should inflate them on listed down here. These 3 seem to be the same, and these are a little less. And these actually come with the correct amount syringe, so it's a little easier to find that size.
So the other ones don't come with the
No,
syringe.
these do not. We used to only have these ones, and now we're carrying these. I think it's a little different in the past.
Okay, so if I have a 10 cc syringe to fill up my ET tube, that's a good enough size, right?
Eventually, yeah, but you probably want to do something that's going to be a little more efficient. You can probably, when in doubt, just grab a big one, and then you have plenty. You might need to do more than one of 60 cc, but there's always less on this, so you can.
It seems to me like
Fill
the
it
60s, which is why we buy that size. We always try to stock those. Is the one that would probably most suit our needs most of the time, it seems like. So, but I think the important thing, especially for all of our new peeps, is that's something that would be very easy to overlook. We use the 5s, we use the 10s, we use the 1s quite a bit, for all the meds and everything that we use. It'd be easy to overlook a big syringe because we so seldom use one of those. So I think it's super important that wherever we carry them, that's part of the required equipment that sits right next to them. So, and you mentioned already too how much air to infill them. Now you said it was printed on the package. Now you and I both know that we have a tendency, as soon as we open a package, especially if my type A ass is around there, it gets thrown in a garbage can or something like that. So where else is it that, what if I throw that away? Is there anywhere else that I can figure out how much air to use it on?
It's probably printed there on the tube.
Yes, so tell everybody where it's at. You're looking right at it.
On the back side of the tube, next to the size number, it'll
Right.
tell you, and also the placement marks.
Excellent.
It'll tell you 60 to 80 on the number 4.
Awesome. So I think that's super important to remember is make sure you know your equipment, make sure you know what sizes we have some rough estimate of what patient it's going to fit into. So like valve, for example, we should probably all know off the top of our head which one of those valves can use. What would it be?
Number 5.
And you're saying 4, and you're saying 5, and maybe he's in between.
Okay.
I was going to say my guess is he's probably a 4. All right, my guess is he's probably a 4. What is the answer? The right answer. How
According
tall
to
are
their
you?
sizings, it'd be
5'10".
You're only
a
5'10".
4.
I figured 6'2".
5 is
4.
recommended.
It's going to be a number
6
4
plus.
then.
So Dion and Ben DeJean are about the only ones on the department that are going to get the. Who else am I thinking about? Anybody else? Big tall guys?
Braden.
Yeah,
Probably.
but most adults, I would think male and female. I think most adults, the 4 is going to be the one that it works on. Whereas if Val's got a 6-year-old granddaughter, what do you think a 6-year-old's going to be?
A 6-year-old, probably one of these 2 or 2.5.
Right.
How tall is she?
How old is
How
which
tall?
one?
Yay high.
4
I would
footer.
say
Probably
2, maybe
3.
even a
So
3.
the nice thing is that in your reference materials that you carry for kids, most of them now have references for King Airways. And actually, I'm going to attach to this presentation a little chart that we can all use. So that'll be good. So sweet. So we talked about what kind. Are those the only kind of supraglottic airways we've got?
No,
They're not.
not. We have the LMA.
Oh yeah. So interesting. That's the ILMA. Where do we find that?
That's going to be in your emergency airway.
Yeah, so in the
Versus-
RSI kit, let's hold this thought for a minute. So we mentioned that an unconscious unresponsive overdose or a trauma patient maybe that's not in cardiac arrest or a cardiac arrest patient that we use it on. The other place, and in fact the reason that supraglottic airways in the hospital environment, which is where these started, this will blow your mind. You and I have been around for a little while. We haven't always carried all these things. I'd consider them a new device.
Right.
Take a guess at when the first supraglottic airway was invented.
1950.
The year Scott Adams was born, 1908, was the
Oh.
first. No, but yeah, 1908 was when the
That's
very
crazy.
first super. Now it wasn't obviously an LMA, but the notion of something that ventilated a patient that didn't go through the cords but sat above it. 1908 was the
Wow.
first one. Now there was a bunch of variations that happened, including the oropharyngeal airway that got developed before that. But the one that we classically think of the most is the LMA, and that started in 1981 and got kind of refined through 1988. And then that gave way to the first generation supraglottic airways that kind of hit pre-hospital, which was, remember the combi tube that we used to have years ago? That was that great big long one. It had 2 different ports that you'd either ventilate through because you could inadvertently intubate with that thing. All right, and it had that huge, huge cuff to it. Well, that was kind of the first generation. And now we're into these second generations, which are these, the LMA, the eye gel, which frankly I think in the next couple of years we're probably going to transition to. Gives us more patience, a little easier to insert, less equipment, and I think there's some advantages to them. But that's kind of been the evolution of them up until these new ones now, which are really, actually really, really good. And in fact, there's more of these that get done in pre-hospital care than there is intubation now. So, but back to the ILMA, we carry that because I started to say in the hospital environment, the LMA came about and the King and all those came about because of, again, the difficult airway course. They talked about as we go through these airway assessments and we make our airway attempts, this thing called the failed airway. So we've not been able to successfully get them intubated, and we talk about the bridge to the failed airway, which is when we cric you, okay? And in that bridge to the failed airway was an attempt of a supraglottic or EGD, extraglottic device, which is where the LMA and the ILMA really gained favor, and then pre-hospital became the LMA, the King, and the combi tube. So we carry in the paramedic equipment, in addition to the Kings that we carry LMAs for the small patients that we may or may not use one of these with, and we carry this ILMA, which is, the advantage of that is you can't intubate through the Kings. We can through that one, and in fact, if you look at a lot of the current literature now, there was a notion that I could run a bougie through this back port, run it up through the front, and that I could actually retro this thing back off and then retro an ET tube over the top of it. And we actually even taught that in the difficult airway course for a while. Now they're advocating not doing that whatsoever. In fact, I said that wrong. It's through the main port. This is your suction port. But you'd railroad that bougie through there to come out, in theory, right in front of the glottis. The bougie'd go in and then you'd pull this out. Well, the problem was you were pulling the bougie out with it. And so now the manufacturer no longer recommends that you do that. The cool part about this one is that we can do that. So after we demo that, we'll talk about this. So we got a few different options available for us, right? So let's say that we're gonna put one of these in now. So let's say first of all that we arrive on a cardiac arrest patient. Let's re-emphasize what Dr. Raskovich has asked us to do about cardiac arrest. What are we gonna do?
Scene safety BSI.
Scene safety BSI. And you got your, are they Korean or Asian? What are those glasses that you got on?
Safety glasses.
Were they free?
Provided by the training battalion here at our department.
That's good. I'm glad to see you wearing them. And this would be an opportune time to wear them, actually, because you could get some junk up in there, right? Okay, so you recall Dr. O came and talked to us about those first few minutes of cardiac arrest management and gave us some direction what he wants us to do. What was that?
We want to position the patient appropriately.
Oh, awesome. So what does that mean?
We want him up in the sniffing position.
Okay.
And that may entail pillow, towel.
And in fact, will, right? So
yes.
let's not will as in Will Elson, my problem child. But no, it will. And so is this sniffing position right here?
So sit him up.
Okay, so we're getting closer. You remember I told people, and I'm going to highlight this because it seems to happen all the time. When we do this somebody and point the chin to the ceiling rather than the face, this is the position that we waterboard people in. This is torture. So what we want to do actually is behind the head. We want to get up underneath the head, and remember we're aligning the ear to the anterior shoulder or the ear to the suprasternal notch and getting them in that sniffing position. Because if I said to you, smell my flower, you'd you'd slightly put your head up and you'd lean your head forward like, smell my flower. Not this, okay? So that's sniffing position, which, by the way, optimizes these two. So what else? So sniffing position.
No.
Bud, what are you saying? You keep doing this over here.
Say sit them up to get that tissues to drop down.
Huge, right? And I will tell you it's even more important with the supraglottic airway because is a supraglottic airway a definitive airway? Is it the gold standard airway?
No.
It's not, right? Because we could still get regurgitation, we could still get reflux, and we could still get an aspiration with supraglottic as opposed to intubation because we don't have that cuffed ET tube through the cords. So one of the ways that we can avoid that is just exactly what Bud was talking about. So how are we going to do this?
On the gurney, just
On the gurney, that makes it super easy, right? Yet another reason, go ahead and do it. We want to be about 30 degrees, right? And then have the head basically parallel to the ceiling, that's going to be right there, okay? So now, all that stuff that's in there is going to stay down there. They're not going to puke. It's not going to do that purple puke thing that you've heard me talk about before, all right? Okay, so we get all that done, and we're at that point now. We've made the decision. You know, both the medics are tied up, and the sheriff's office is on its way. And you've made the decision. We're going to put a king in. We've properly sized it. How are we going to do it?
Well, we're gonna take this off, and there's multiple ways that we can do it.
Okay, tell us.
Biggest obstructions are the tongue.
Okay.
Dropping down, we're not going to replace it. If he's already got the OPA placed, and we can go off the side of that, or if we're having a hard time getting it through, then we can pull it out, pull the tongue back, and then drop that tube.
Okay.
They talk on our King Airways. We have the blue line. When we go to insert it, we want it to this corner of the mouth.
Good.
And with him, we may not be able to go with the OPA.
Okay.
So we'll pull the tongue, corner of the mouth. Once we get that past, then we'll twist it to where that blue line will
Try to set that just a
go
little
towards the chin.
bit. There you go. This guy's a little harder to do. His mouth opening's smaller than the Laerdal mannequin's on. Okay, but even just kind of, so keep walking us through it.
So we keep it twisted, drop it in,
Okay.
and we're going to get it to the base.
And when you say the base,
The
what do you mean the
of
base?
this
Okay.
connector
And where does that base of that connector go?
to the teeth.
Okay, generally, and I know on this mannequin it's hard, but in a real patient, what we want to do is that'll go to the point where the bottom of that, not this flange that's around the top, but at the bottom where you can see the colors, that's going to be sitting essentially right at the patient's teeth. And I got a picture of it. We'll show everybody. So, and then what?
So once we're placed, we want to fill it to what it asked for. So whatever size tube.
So if it says 60 to 80, I want to make sure to put 80 in it, right?
we want to go as least amount as possible
Okay,
to get a good seal on it.
That's the important thing for us. What does the protocol say we're supposed to do on this?
There's actually not a protocol in place for the King Airways.
And who was the most surprised person about that? I was sure we had a protocol for it. I thought we did years ago.
We looked and looked and didn't find it.
Yeah, we married it into just the overall airway encounter or the airway management protocol. So it is not specifically addressed, and that's the other reason we wanted to do this training. Awesome. So you've inflated it. Now what? Is it going to work no matter what?
Now we need to bag. We'll acetate.
Okay.
We'll,
There's the bag. Maybe Val can throw the bag on there.
So we're going to listen for look for a good chest rise and fall.
Okay.
And I'm getting some blow by, so we need to add a little bit more on there.
And you may on this mannequin anyway.
And then as he fills that up, it kind of backs up a little bit just to seat there behind that tongue, that back cuff.
Okay.
So we're looking for a good chest rise and fall. We can do capnography. We can do pulse oximetry.
What's the best one?
Capnography.
Yeah, capnography. So just like for intubation, it's our gold standard. It is with this. I mean, we'll pull, if we've got good perfusion going on, we should pull off good capnography. And that, in fact, is probably the biggest thing that I've seen with the auto pulse and good attention to CPR is we're pulling capnography off people right away. Awesome. Cool. And then what? So is that thing likely to migrate?
It's possible. We want to secure it with twill tape.
Okay.
And then we also want to document where our placement, where we're getting good ventilation.
Good.
So we're at 15 at the teeth now. We feel like we're bagging all right, and so we'll secure that.
So I will tell you more and more and more and more. I hammer people when we do I was down at UVU teaching the new medics the other day, and I hammer people about don't lose that tube. So I jokingly say we should be able to pick this patient up by the tube and walk them in, holding on to the tube. So if you end up twill taping that, and then taping it again, and Mark Hoyt pulls out his tape and chevrons that thing on there or whatever it takes. It's so super important that we not lose that tube. And what would you guess I would say is the number one thing we have to do to not lose a tube other than tie it down?
Keep one person on airway.
Right.
And
even more than that. Calm
coordinated effort.
down. Yeah.
Coordinated movements.
Calm down. Once we're getting somebody ventilated, as long as we're managing all the other things that we have to manage, the crisis is over. We're oxygenating now. We're ventilating now. We're not at risk of aspiration, at least far significantly less risk of aspiration. Now's the time to get everybody to calm down, because we don't want to take what may have been a really tense situation and make it bad again or worse again because we did something stupid just because we didn't calm down, right? Awesome.
I've got a question for you.
Sure.
So as we got this placed, and then we talk about having twill tape, and some of these rigs we don't carry it, or
Good point.
it comes up missing. Can we use the manufacturer's securing devices? Will they fit on them? Or is it?
So I think you could on some of them. Like the smaller ones, you could for sure. The 4 and the 5, I'm not so sure. So maybe what we should do is have everybody practice doing twill tape, because if you've not put a half hitch on one of these before, especially now that we're using the manufacturer's recommended securing devices, if you're not used to putting a half hitch on these things, it can be a little bit of a challenge. So after the video's done and we all get together as crews, that's a good thing for us to practice on and find out which ones we can and can't put that tube holder on. All right. So I'm going to pull the bag off for just a minute, Val, and we'll leave that in there for a minute. So as you were kind of preparing, because I mentioned to you today that we were going to do this, what thing did you find when you were studying that you thought, oh man, I'm glad I found that, or I wish I'd have known that, or I need to remember that, or what take home do you have from all this?
I never heard that you could pass it past the oral airway and use that as a mechanism to hold the tongue. I'm always a little weirded out to stick my fingers in a patient's mouth if they're going to clamp down on it.
I noticed you put your fingers right in there. You weren't worried. I'm a finger in the mouth kind of guy.
I'm a finger in the mouth kind of guy.
Yeah, I'm okay with that, but some people aren't. So.
And if you attempt it with this, I mean,
sure,
we have that. We have the finger in the mouth. We can do the blade.
You could put Roxanne's finger in the mouth. What about you?
That'd be a good option.
What's that?
I think that'd be the best to
Yeah,
try
I like
right
that.
off the bat.
Yeah.
Well, it's already in there, and
When
give
he
it a pull to the
when
side.
he brought it up today, I hadn't even thought about that. Go ahead,
Yeah.
get that again real quick. Yeah, so like I said, I hadn't even thought about that. So, what about you? What one thing did you want to really remember? Or if I asked you to teach everybody something, what one thing would you say?
Know your equipment. Know where it's at. Know if you need anything extra. One thing that we've kind of missed on this and didn't talk about because the dummy's pre-lubed is it comes with water-based lubricant. Make sure that we're proficient in our skill set.
You're absolutely right. And without being hard on the department or harsh sounding, this one skill, if you will, really showed itself when we did that assessment that we were struggling with kinks. So to the captains on the department, I hope, advanced and paramedics alike, that you'll pull these out, you'll have the conversations after you've watched the video, and that you'll come back in the back of the ambulance or go into the fan room of the stations, sit in a car. Don't just do the usual thing that we do when we practice. Practice some of those unique situations where we may find that we have to do this. So you mentioned it, you didn't say it really, but practice. I think it's so super, super important. And we don't. This is a high-risk, low-frequency event for us. Simple reality, right? A couple things. What about you, as we've sat here today? Whereas you've thought about calls that we have used them on?
I think the biggest thing is just like we're doing right now, getting them out and using them. I mean, it's easy to look at them in the bag, but to actually try and stick them down in there is a whole different story than, so just the hands-on part of it, I would think. But.
A cool thing, we Aaron and I and Kyle went down to Vegas to the EMS Expo, and one of the things they had us do was go through the exhibit hall. Aaron came across this awesome airway mannequin that's cheap, and I would bet by the time that we've got this out that he's either bought them or they're already delivered to the stations. We're going to have an airway mannequin per station that we can bring in the back of the rigs, and we can go do the things we just talked about. So there's really no excuse anymore. It's not the paramedics airway mannequin. It's the department, and every station's got one, so we're not going to have to run back and forth to the stations like we usually do. So that'll be awesome. So a couple things. Attached to this, like I always do, I want for all of us to not just only do the hands-on stuff, but I've got an awesome PDF. You heard me mention at the start of this month, in this month's EMS World magazine that comes out, in October, which ends up floating around the station if you haven't seen it already, is an article on this that I've also got the PDF version of it. I've attached this. I would like you all to read it. I actually went through and highlighted in it what I felt like were the real important take-homes, or the things that, as I've taught this or as I've been on calls and noticed that we're struggling with, or that we struggled with in the thing, I highlighted some of the teaching points that I think are super important. It talks about in there, but I think it's worth highlighting, 2 studies. And this is probably a good place to finish on. As you probably well know, Dr. Raskovich, as is all of the medical community now, especially in pre-hospital care, really focused on good evidence-based medicine. So not just stuff that we think works, but what we know works or what we know doesn't work. So a good example is, we know backboards don't work. Thank God they're gone, right? But when it comes to these, there's 2 important studies that, again, it mentions in there. I'm not going to beleaguer it too much, but I used to reference all the time. There was a pig study that was out for years and years, and it was the first generation, so the big combi tube ones that it specifically looked at. But what it found was in that study that was when they inflated that great big cuff at the top of it, that it would push that tissue away, which is how it got its seal. And if you had what I would always refer to as a no-flow, low-flow state, so perfusion, blood pressure, moving blood to the brain, that it was tamponade blood flow to the brain. And so maybe these things weren't the best thing to use, especially in a no-flow, low-flow state. So we still could in that trauma patient, as long as they had blood pressure, the overdose patient or whatever, but maybe not in a cardiac arrest. So they recently did a human study, and they had a neuroradiologist, several neuroradiologists look at it, and what they found was, under fluoroscopy and all the other ways that they have to do imaging, that it doesn't appear that it does interfere with blood flow to the brain. So there's that study that says, yeah, actually you probably can use them in cardiac arrest, and maybe you should. And in fact, what it did was lend itself to another study that just came out, and I've linked it again to the video. And what they looked at was rates of return of spontaneous circulation, survival to neurologic discharge, if we used a King versus we intubated you during a cardiac arrest. Which do you think you had better chance of ROSC and better survival to neurologic discharge? Intubated or a King?
Intubated.
It actually was intubated. So now there is still that discussion about what are we doing to the brain during cardiac arrest. Now, they'll be the first to tell you in that study, it depended on CPR. Most importantly, it depended on how good were you at intubation. Did you have to stop CPR? And so I will tell you that with us having video, and with us having guys that I believe overall are very good to very good at intubation, that we should be able to intubate somebody under the video while still doing chest compressions, and that will probably help them get ROSC better and help them survive to be a taxpayer instead of sucking on a vent down at South Davis Metro. However, if for whatever reason your medics on a call are finding that they have to stop CPR, then the answer needs to be we need to go to this. All right. If the intubation is so difficult that we have to stop CPR, then we should be going to this instead. And so the studies are kind of a mixed bag. They're leaning more towards you probably can use them, but there's also evidence that it doesn't. It maybe does have an effect on our survival rates. So look at those studies. Read the PDF. Like Val and Brandon said, I think the most important thing is pull these things out. We can order more. I'm sure some of them are already expired anyway. And if they're not, Kyle's got lots of Brad's Wildland money that we can spend on equipment and training equipment. So get them out, use them. We've got DATC trainees here. We've got new people that we've both hired and that we're hiring. There's absolutely no reason that you shouldn't be super, super confident when we next do the evaluation. If I pull up this as a skill, that we're good at it. Anything else you want to say?
No, I think it was good training, though.
Thank
I
you.
like
When
it.
are you going to take us all on vacation with all the royalties you make off these things?
Well, I'm working on that.
What about you? Anything else?
Nothing. Thank you.
Absolutely. Good. All right. Thanks, everybody. And I mentioned this before. I've got 1 or 2 other recommendations for things that we can do for skills-related stuff. But if there's something you would like for a crew to come back here in the back of the bus and do some training on, then we'll do that. So otherwise, take care, and we'll probably talk to you in a month or so. Thanks. I'm going to leave that in. You know that. Okay. Awesome. Thanks, you guys.